Warm welcome to this afternoon session with Seeing Through Transparency. My name is Mats Bojestig. I'm a part of a strategic advisory board. I will be chairman during this session. So what is important for me is to introduce our speakers. I would think it's a very good friend of mine. First, Robert Lloyd. He's a fantastic teacher in how numbers can become almost like movies. How you really can visualize the results in new ways that bring you into action. He tried to learn me these control charts in 1996, and I'm still a beginner, but I love the way he do it. So. And then and he's working for IHI. I'm sure he will do it more if I don't do this probably. And then it's Alide Chase, Queen of Kaiser Permanente. She's a quality senior president, and you will listen to one that brings energy into quality work in a new way. And she's also bringing that to all us others. But you will also recognize that it comes through very hard work. So, Robert Lloyd and Alide Chase.
Thank you, Mats.
And this is broadcasting, so if we have any friends everywhere, you're very welcome. And I will also stimulate you to Twitter. We have 2 disc jockeys here. And they are ready to. So start twittering, because it's not so easy to get the question from the back.
All right. Thank you. Welcome. Welcome. Alide and I are very pleased to be able to present this topic today. It's actually the first we've presented it at any forum, and we've been looking forward to having the chance to share with you some ideas. What we're going to do is to set the context for transparency. It's a topic that has become more and more popular, but yet we find that it's very confusing for many people. So what we're going to be doing is talking about these 3 things. We're going to define transparency. I'm going to give you a quick walk through history then and now about some of the things that are going on in transparency land. And then Alide is going to give you an example from Kaiser Permanente and the work that we've been doing for nigh on the last 10 years to think about creating data, releasing data, who needs it, etc. So let me just start by thinking about what does transparency mean. This is from the dictionary. You can go find all these great terms, but I love the one on the bottom. A colleague of mine who asked to remain anonymous after he told me this, gave me this as a statement. I frequently use term in healthcare settings which has no apparent consistent definition or meaning. And that was exactly what Lita and I were thinking about as we put this topic together. And I'd like you to think about that in terms of your own context. So what I did was to start thinking about what are some of the key questions. And Alide and I sat down and just brainstormed. And I put together these 2 worksheets for you. There's 2 of them. And when you print out the handouts, you can actually do this. And I'd ask you to take this little quiz just to understand where you and your associates are. It'd be interesting to take this back. And you do it, have others do it, don't talk, and then come together and share your thoughts and answers on it. It's a forum for a dialogue, and not a debate, but a dialogue. And if we don't have a dialogue on the richness of this notion, it's not going to be as full and rewarding as it could be. And so in the first part of this, what I've done is ask you about general questions, starting with a statement. Greater transparency is needed across all healthcare settings and providers. Patients should be able to compare hospitals as easily as they do cars and other products. And then just asking you in terms of your own beliefs, whether you strongly agree, just a 5-point scale in terms of where you are. Notice that I go through on the second set of questions asking you about the time periods. Do you think data should be released every year, once a year, twice a year, 4 times? And then getting into doctors. Do you think that groups of doctors should have data released on them? Surgeons, OB-GYN, critical care. And do you think that individual doctors by name should actually have data released? This is one of the more controversial aspects of this. Second set of questions get into content about outcomes. and whether or not you think all outcomes should be made available to the public. Operational outcomes, including wait times, referral times, access, patient satisfaction, financial status, including salaries and operating budgets, mortality rates, infection rates, errors, and finally, salaries of individual physicians should be made available to the public. There are places in the world that are doing all of these. Matter of fact, I originally did my work in Pennsylvania back in the United States, working for the Hospital Association of Pennsylvania for 10 years. And in Pennsylvania, there's a state data commission that lists individual physicians and the money they make. Now, that's a transparent system. Not real popular with a lot of people, but quite transparent. So I want you to take time to think about these questions, because people talk about this stuff. I mean, it's almost in there with friends and love, transparency, and everybody wants to be transparent, but I find that it really sends mixed messages. The next point is that transparency is not new. I want to talk about 3 people who actually set the context for all that we're thinking about now with transparency. Do you recognize these individuals? You probably recognize the first one. Who is that? Shout out.
That's Flo.
Florence Nightingale, right. Who's the second one? Aha. Who's the third one? Aha. All right. So first of all, let's talk about Florence Nightingale. And I put in your notes a little summary. Now, most people, of course, know about her. The thing is that Florence was the original data geek. She was a nurse, worked in the Crimean battlefields, etc. But the thing about Florence was that she actually collected data, much to the chagrin of many army officials and leaders at the time. Because what she did, as I summarize here in the bottom of the slide, is that she started putting data together and then making graphics. And what she is most known for is what's called the polar area diagram. You may have seen these in some journals and history books on healthcare. And the dark colors represent wounded, deaths, injured, and then she categorized them. And one of the things she did in terms of using her data is she found that the higher ranked people were getting better attendant when they were wounded than the troops. And so one of the things she was able to pull off, which is amazing, is that she got the couriers, the equivalent of ambulance, the carts that went out into the battlefield, to strip the blouses off all the wounded so that you couldn't tell if they were a general, a colonel, a private. And so they all came in with just their T-shirt, undergarments on, and everybody got equitable treatment because nobody could say, ooh, treat that person, they have higher rank. She was quite criticized by many for doing this. So Florence is our first data geek, if you will, in terms of actually having transparency. The second and most controversial is Ernest Codman. Now, Codman, if you've not heard about him, was a physician in Boston, very well renowned, but he got himself in a bit of a difficult situation because he is the one, and you can just scan these summaries that I pulled on Codman from this article in particular by Swenson and Cortez from the Mayo Clinic. But he's well written up. And what Codman said, he had what was called the end results approach. And he believed that every patient should know everything about every doctor, every hospital. And if you didn't, it was unethical. He was so sincere about this that he opened his own hospital because he felt the hospitals that he worked with in Boston were not open and transparent enough. He was finally vilified as a heretic and thrown out of the Boston Medical Society for his values and his beliefs. But Codman is the one that actually is seen as the first original transparency supporter. And if you really want to understand the history, the things that bring us to this moment in time, you really need to understand what these folks contributed. The last one is Francis Peabody, a lesser known, but he was highly regarded. He didn't get himself in trouble like Codman did. What Peabody did was write, and he taught the medical students what he said was the secret of medicine. That is that the care of the patient is all about caring for the patient. And he believed that everything that doctors and providers did should be public, it should be shown, and as I show in this bottom quote, he believed that you should give your patients all the information that you're doing, you're thinking about, and what you've done to them, and why. He was also criticized, but he wasn't as outspoken as Codman, so he was still quite highly revered in the medical circles in Boston and the East Coast of the United States at that time. So today, it is a very different situation, though. You know, back in the 1950s and 60s, when people went to a physician, they said, "Thank you very much. How much do I owe you? When should I make another appointment?" They don't say that anymore today. What do they say? "How many of these procedures have you done? What's your infection rate if you're a surgeon? Do you have any malpractice claims against you?" And then the ultimate insult comes when they pull out a piece of paper and say, "This is what I got off the internet, and this is what I think's wrong with me." It's a very different environment, and as more and more data have become available, more and more people have been getting involved with this transparency discussion. I just want to show you a quick walk through countries. I'll start with my home country of United States. There are many organizations that actually rate and rank. This is from the Chicago Tribune. I live in Chicago, Illinois. Hospitals in the state are rated by the State Data Commission, A to F. And all the hospitals are listed. Here's the entranceway of Jackson Park Hospital. And as you go through this, the language is fascinating when you read these things. They talk about the good, the bad, the ugly. Some give star ratings. Some do yellow, red, green rankings. I've seen some that give smiley faces on how happy people are when they go there. One of my favorite was that they had apples. And if you got 4 apples, you know, an apple a day, health and all that stuff, and somebody says, "Well, we don't always have whole numbers," and this group came up with taking a bite out of the apple, so you'd get like 3.5 apples. I mean, it is amazing the stuff people come up with to try to rate and rank. The issue is with a rating and ranking, somebody's always going to be at the top and somebody's always at the bottom. The question is, what's the variation in practice? What's the reliability? And what is the current performance? Because most of this stuff is lagged up to a year or two in the United States, unfortunately. And it is not unlike that in other countries. In the United States also, since we have an insurance program where you have to buy health care, we don't have a national health system. We have a sickness system that works pretty well if you get sick and have to go in the hospital, but it doesn't do a lot to keep you out of the hospital. And so as a result, we have to pay through our worker insurance. If you don't work, you don't get health care coverage. It's that simple. And as a result, there's a lot of interest on employers' part. Midwest Business Group on Health, shown here on the right side, they are one of the largest business coalitions. They buy health care packages. They commission, in some cases, health care services, and then they endorse groups and say, go to them, don't go to them. So large companies like Westinghouse, Ford, will listen to groups like this and decide where to send their employees. Medicare, the government program, CMS, Centers for Medicare and Medicaid, has their own website where they rate and rank. I used to work for the largest health system in Chicago called Advocate Healthcare, and this is just one of my hospitals, Good Samaritan Hospital. So you can just type them into the government's website, and you then get all of this information. You get the hospital, and this is patients who reported that their nurses always communicated well, received help as soon as they requested it. So you get your hospital rating, and then you get the Illinois average and the national average for comparison. There are other groups, probably the most best known in the United States, a group called Leapfrog. And if you go to their website, it's a fascinating little walk through how they decide to measure, what they measure, how they do it. But the interesting thing is when you click on them, and so here's another one of my Advocate hospitals, you get little bar graphs on various things. Preventing medication errors, appropriate ICU staffing, steps to avoid harm, etc. And you can go down the list and look at various hospitals. Here's another hospital, here's a third one. And what's interesting is more and more groups are starting to put stock in this. Well, as you well know, if you pick different measures, if you analyze them differently, you come out with a different rating, right? And so this group, I just put this in literally as I left the other day. The American Association of Retired Persons, ARP, the association for people that are of over 50 years of age, and they do a lot in the senior area. They just came out with this rating. They took the Leapfrog ratings, and then they listed these as the top hospitals in the United States. There's over 5,600 hospitals in the United States. They picked 66 of them and said these are the best. And if you look at these, you go through, this is the first listing here, you can see a few of them. What happens is that you start to see that some of the big name hospitals, that if somebody said, ooh, what are the big hospitals in America that are good? Some of them aren't on here. Why? Different set of measures than maybe what they saw in another one. So as you go through these, the confusion in the United States right now is that there's so many groups trying to be transparent with your data that it's hard to figure out what's right, what's wrong. This is a great example. This is St. Mary Mercy Hospital up in Michigan. The interesting thing here with this article is that they were rated on 4 different issues. So 2 of them, Leapfrog and Health Grades, which is another business-related coalition that rates and ranks hospitals, they ranked high. Interestingly enough, Consumer Reports, that rates and ranks all kind of products, now they're rating and ranking hospitals and they want to move to medical groups. They were an average rating. And by U.S. News and World Report, in their ratings, they were unranked and down at the bottom. So what is a consumer to do in this transparent release of data? One says they're the best, another rating says they're not so great. And it's very confusing. Now, as we move to other countries, it's a little different situation. You know, in the UK, particularly in England, it all started with the Bristol Inquiry back in 95 to 1991 to 95. That was then promulgated by increased interest on the part of the BBC and newspapers. Example here, The Guardian, back in 2005, where they started listing various errors and other things, all pressured by the Bristol Inquiry, which started a great deal of debate in England. Dr. Foster came on the scene, and this was what their website looked like in 2006. And you could pick a hospital. Here's Luton Dunstable that I just happened to pick. And you get all these different ratings, and then they compare them to Barts in London, Royal Free, Guy's, etc. And you can do that very easily on a national database. This is what Dr. Foster looks like in 2013. Still going strong. They rate, they rank, they compare people. How many patients do you think actually go to these sites? Or are these policymakers? Are they people interested in writing articles? It's a very interesting set, but at least what I find is that you have some commonalities in many of these sites. This has been obviously capped off by the big issue here in England, the Mid-Staffordshire report and the Francis report. And this is going to increase even more and more the demand for transparency of data at all levels. And I would bet that what's going to happen is there's going to be a press for more transparency in more current time, rather than looking at these lags, because it took a while to even figure this one out. Now, when you move to other countries, my good friend Mats and I have had a wonderful time working with something called Open Comparisons in Sweden. This started a number of years ago, where they rate and rank all 21 counties in Sweden. And then you can look within a county. And then they started making other reports, as the second one here, on cancer care. Now, the Open Comparisons were first listed as quality improvement, but over time they have slid, and people are starting to use them for data for judgment, where they go, ooh, good, ooh, bad. And what we're struggling with now is getting people to realize that these high-level outcome measures can, in fact, be used for improvement. But many people are into the debate with transparency of data for judgment versus data for improvement. Now, this is a new one. We've started to work at the IHI in New Zealand. And when I was last there a couple months ago, this was the headline in the Auckland, New Zealand Herald, right? Death rate figures reveal best, worst of our hospitals. And you can imagine the language that was used in this about pointing fingers, rating and ranking, etc. The second page of the article I found most intriguing, where they show the cadaver with a tag on its toe, and then start listing the hospital mortality rates by hospital and making some comparisons. And you see this in every country. It used to be that the United States was quite keen on this because we buy health care individually. And so there was a lot of interest in rating and ranking. But it does not matter whether you're a national health system, a mixed system like we see in Canada, an indemnity system as we have in the United States. More and more, the customer, as patient, family, staff, all people are starting to ask for data. And the question is, how prepared are you for this venture? I think it comes down to this type of a quote. Ken Kaiser, who was president of the National Quality Foundation. Now, this is back in 2004, and it is originally a statement made about America. But here's the key. The whole thing is about value. Are we really getting a good return on our investment? So I find it interesting, even when I rode out here from Heathrow the other day, my cab driver, I said, well, what hospital would you go to if you needed to? And he goes, well, you know, here in England, we have free health care. And I said, I'd like to take issue with that. It is not free. You pay for it in your taxes. The Swedish system is not free. Somebody is paying for it, right? And it's all about value. And so when any group says, now we need to get more value, what does value mean? And they're thinking that transparency is going to land them understanding of what value is all about. The cost, the quality, trade-off. So as you think about this, there is more and more pressure. This is a slide that I made for a group in the United States, a large medical clinic, and this was the comparison of individual doctors. I have taken their names off the bottom, but when I did this retreat, they actually had this masked, and when they came in, it was a board retreat, they asked every doctor, and every one of the doctors in this family practice was asked to put his or her initials by the dot that they thought was them. And so everybody was fighting to be the 4 dots at the top of the chart. Nobody wanted to be the dots down here. You know, they're all shoving and dropping their coffee and donuts. You know, I don't want to be that. No. That is me up here. You know, no, you took that one. Okay, that'll be me because I am above target, right? And so then they pulled off the label and revealed it. There were some very shocked people. That's transparency. So let me just end this overview by talking about Atul Gawande. Some of you know the name. He's a well-known surgeon who's written a lot in America. He's one who started some of the checklist stuff and talks about life and error as a surgeon. He wrote this article, and he noticed what he says. It assumed that the difference among hospitals or doctors, or particularly specialty, were generally insufficient. This was a study he did on cystic fibrosis in kids. And every place he talked to said, we're the best. And when he did, he looked at the data. People were basically telling him that what they thought was that they would be like a shark fin curve, he said. That's how they explained it. That we are up here, and anybody else is down here, poor. But we're really good. And he points out in this article, after looking at the data, that what you find is basically that it is a bell-shaped curve. You get a few people really bad, few people really good, and the bulk of people kind of falling under this humpy bell-shaped curve. But that's the reality of life. But yet people have a different perception. And so what he wrote very nicely is that we tend to find a bell curve, a handful of teams with disturbingly poor outcomes, and a few with remarkably good, and the great undistinguishable middle. And I think a lot of transparency work is aimed at trying to figure out what is hiding in this undistinguishable middle. All right? So, with that as a backdrop, Alide is going to walk you through the journey that Kaiser Permanente has been going through on their journey toward transparency.
So I want to start. Let's see what just happened. Did I push the first? This one right here. Yeah?
That should do it.
It should have did it. It did it when I was practicing.
Okay.
Okay. I wanted to start by saying I don't want to come across as saying Kaiser Permanente has solved the transparency problem. I'm here to sort of talk about the journey that we had in transparency, and I borrowed this slide from IHI, and this originally is what we call our slide towards system-wide transformation. If you look at the steps, which I bet everybody in this audience is familiar with these steps towards transformation, sort of that period of will building, then getting ideas for improvement, and then execution, both at the macro and the micro level. You can sort of think through, well, where does transparency as a strategy, transparency as an endpoint, where does the value and the philosophy of transparency contribute to your ability to transform as a system? And I would contend that you're going to find how you behave as a system, your values and beliefs will affect every step in a journey towards system-wide transformation. If you believe you're fabulous, like Bob described the 2 physicians at the beginning as a system, but you have no data to support that, you can maintain that belief for a long time. And the will building about sort of holding up a system's level of performance is a fabulous way to play catch-ball as a system, to acknowledge that you're not perfect and to start sort of the momentum in an organization for the improvement work that you then use transparency as the vehicle to get the will built and the action started. And then when you go to the other side of the equation on execution, if you don't have transparency around performance at both the micro level or the team level and the macro level at the system level, you can't actually figure out whether you're making the improvement that you wanted to make across the system. So I'm going to quickly give you the end here of lessons learned and then go backwards. So in our journey for transformation, again, back to my point about is transparency an end or a strategy towards an end, we found that it was very effective in helping us hold a mirror up to ourselves, look very honestly, despite our self-story about how well we were doing, to go, we are doing very well in certain areas, but there's other areas we could improve. We started the journey several years ago. I think about it in almost the same theory that we all know around social movement, that you have to sort of employ a social movement philosophy as you're doing this journey and applying the science and the data as you go each step in the way. We believe that system-level measures were absolutely critical in our transformation itself, and that also our leaders had to learn how to read data, translate data, and inspire using story to augment the data itself. And I also put in here, for those of you that are in jobs like I have, that it's not for the faint of heart. I don't think I've ever presented data to a medical group where the very first thing that came out of everybody's mouth was what? Your data stinks. It's wrong. It's inaccurate, right? So you have to be sort of tough in this business in order to take the arrows, keep working on cleaning up your data, because 9 times out of 10, it is wrong. You do need to become more accurate as a system as you gather data and report data. So I say bring on the arrows, clean up the data. When we both agree it's accurate, then we'll talk turkey about how to improve together. And it seems to be a very effective strategy. This is a big aim, and it was set out. We have 37 hospitals in Kaiser Permanente across the United States, but mostly in California. And our hospitals, in a minute you will see, we're performing very well on some indicators and delightfully average on others. And we had some that were what we would call lower performing hospitals. And our CEO, when presented with the information, set out a bold aim or a bold vision. I'm not going to read it to you, but he basically gave us a year and a half. He got all the CEOs of all the hospitals, all the chiefs of staff together and said, we want to move towards best. So that was that big vision and the aspiration. This diagram, you can't read all of it, but you certainly know this theory, which is once you have that big aim and you decide on what strategies you're going to use, that you create a dashboard based on the data that you have available, and you start reporting your system's performance, your system-level performance, and you set goals around the key areas that you move within the strategy. And I'm now going to go backwards and show you a few for us. And I know you can't read this, but it's just this concept that once you have that big vision, and whatever you see as the key things you're going to work on strategically, how then you move to a dashboard for performance and targets. We developed whole system measures. Now, this was across 400 medical offices, 37 hospitals, continuing care, skilled nursing facilities, and affecting the lives of about 9 million, what we call covered lives in our system, or a managed care system. And we had to learn how to grapple with multi-year goals around whole system performance and then readjusting the most third year out every time we finished a year, because it's an inexact science. But if you don't put a stake in the ground, you don't start on that journey. So you see here I pulled a few out around where we wanted to be in population health, because we're more than a hospital system, as well as in population care, which is how we take care of people with chronic conditions, and in inpatient services. Those are examples. We have about 11 of them across our whole system, all on 3-year time frames, all so that we can improve, watch our improvement across the whole delivery system. So what did we pick? This is not to say you should pick these, but it's an example again about what we decided was important for whole system performance. These were picked out in 2005 and 6. But under clinical effectiveness as a system, we looked at our risk-adjusted mortality, which is the HSMR. We looked at some key processes in the United States called the Joint Commission core processes, and a standard for ambulatory clinical chronic care and prevention. So that was clinical care. Safety was never events, bloodstream infections, pressure ulcers and falls. Risk management, which I'm not going to go into too much here because you don't have quite the same model. Service was how people were feeling about the customer experience itself. And then cost, which we called resource stewardship, or being effective stewards of our members' money. Now there's a light dot there because since that time we've developed another whole area of whole system measures, which is equitable care. That wasn't one of the original ones, but it also shows that a system matures. And this you can't entirely read, but it was our very first creation. We give this to our board of directors. We give it to our most senior leaders about how we're performing as a system. I tell a quick story that my first board report to our board was 2,000 pages long. It had so much data you wouldn't believe it at the microsystem level, and one of our board members followed me down the hall and he said, Alide, I just have one question for you. Yes, because I've got 2,000 pages, and he says, how are we doing? Now there you are. You know what I mean? In terms of actually giving a clear picture. So we've overwhelmed people with information, data points, but we've not actually I was not able to talk about how our system was performing. It was a very breakthrough moment for me. And by having a whole system measures with the help of this gentleman here, we were able to start saying, we're going to talk about how we're doing as a system at the macro level on these measures to get ourselves started. This data system now has about 100,000 actual data points, because you can drop down through the system, through a geographic area, through a hospital, through a unit on any of these measures across our whole system. To give you an example of further advancements, we're now going into population health and trying, in addition to measuring illness and the inpatient experience and even chronic conditions, to start developing whole system measures on the health of our population, in addition to how we're performing as a system when they're ill. So here's my advice on measuring progress to goals. We learned that we needed to be transparent with our performance, to celebrate high performers, to be attentive to low performers, to create a multi-year approach that aligns with accountabilities and incentives. And we do, at the system level, have incentives that drop from the chief executives all the way through the system. Now, how did this all work out? I brought a few slides. This one is our risk-adjusted mortality. So this is public information. You can see here that when we started 2008, third quarter, each of those gray dots is a hospital. We had a lot of variation. We actually used Dr. Foster, that system, to help us to have a standard. And when you look at us at second quarter 2012, you can see that we've had a significant reduction, and the hospitals are actually overlapped, so it looks like we have fewer, but they're just laying on top of each other. We're now, as a system, well below the U.S. average for risk-adjusted mortality. Now, I also brought in some examples of physician-level data that's reported internally. You can see here an adjustment. This shows a physician, the comparison of CT procedures at the individual physician level compared to the department average. I've blinded the names of the doctors because we're doing a public talk here, but they would see themselves and their colleagues, and we share in our system where everybody knows everybody's performance within a department. This is a different way of expressing the same information that talks about the individual provider. So that provider is the red line compared to the department average. Now, let's talk about publicly reporting. I brought you a sample, but you can actually find it on kp.org, of the type of information on our website that we share with all of our members as well as the general public. This is the Joint Commission, where we don't make the members go to their site. We actually drag the data into our site to say this is how we're performing, so that it's easier for them to understand our performance right in our own site. And this is one, Bob talked about infections in the hospital. This is on our public website. So it's a little explanation so that the public can understand it. We have people help us to write it in more lay terms than scientific terms, and then we have ourselves, and if we don't have a national benchmark, we quote what we will agree to as from the literature an acceptable standard. So where are we, Bob? Do you want to pick it up from here?
Well, I think the interesting thing, we're going to have just a little kind of talk show dialogue right now between the two of us, because Alide has offered a journey. And so first question I have is whether or not you have all taken steps to have this dialogue within your own organization. I know many of you come from countries that have national systems that report some sort of data, but do you know your data better than anyone else? And are you taking steps to strategically drill down from the macro to the meso to the micro level in terms of your outcomes, as well as the structures and the processes that drive those outcomes? And so when Alide shows you this, that how they actually report some of these measures, they are actually one of the leaders in the United States in being transparent. There's a lot of groups that would say these folks are out of their mind. Why would you ever let people see that stuff? If the public doesn't criticize you, surely a lawyer will get a hold of it and start to make some argument for some customer that when their father died, your rates were higher, and therefore it shows that you're not attending to issues. So you've gone through a lot of stuff, Alide. Do you sit and worry about what Leapfrog, business coalitions, Medicare, all the different ratings, or do you just go about doing the work figuring that those ratings will take care of themselves? Do you sit around and worry a lot about all these ratings and transparency?
I sit around and worry about those ratings a lot.
Oh, you do?
Yes. But that doesn't mean that I have faint of heart in still putting the data out there, and it's not about me, it's about our whole organization. Let me give you an example. Leapfrog, I don't know internationally, but in school, do you get A's through F's, or is it just a U.S. system? Is it U.S.? F is bad, A is good. So they put a system out and produced, A's through F's, and we had 35 of our 37 hospitals receive A's. And we had a big celebration. So who called me immediately? The two B's. Mm-hmm. What the heck? What criteria did they use? What happened? What's wrong? How can we change this? And we went through the scoring system and said, now you can. I mean, this is the area you're going to need to improve in. So I find, again, that the use of transparency as a strategy to incent, to bring performance up. So it was very helpful in terms of the brand of those hospitals to receive those A's. They really felt good about that. But also, and I don't consider a B bad, it's still above a C, which is considered average. But it was, I'm telling you, there was less than 24 hours between the public posting of that and when the two hospitals that received B's were completely on it about what they were going to do to improve their performance.
The second question I would ask is, when you look at a lot of these measures, falls, pressure ulcers, infections, these are basically outcome measures. So behind this, though, I know from having the pleasure of working with you that you are looking at the structures and the processes. And it's one of the things that I've found in working in Sweden, in Denmark, parts of Africa, the Far East, is that typically large systems or countries look at outcome measures. And then the workers, the people providing care, say, well, you're picking on us, these outcomes, but the assumption is that you will own the processes that produce that outcome. And if you're not tracking process measures as well as structural conditions, that outcome is never going to change. And you can harp on that outcome till your face turns blue, and it's never going to change because you're not attending to the structures and the processes. So you might comment on that our whole systems measures gives you the ability to keep drilling down to the structures and processes, because that's where they know change will happen.
Let me give you an example. All the physicians in the room know that just reporting the blunt sword of HSMR of your risk-adjusted mortality doesn't point your nose in a direction to go, if it's low, what are the next steps? You actually get interested in the number, generally, but then you have to drop down to the unit level. You have to drop down to the ICU and start looking at your surgical data, your pediatric data, and then even farther down within that to look at sort of the intersection point about the data around infections, surgical outcomes. So I don't want you to think that a blunt whole system measure such as risk-adjusted mortality is the end of the story, because in my mind it's the beginning. It's what creates the curiosity to want to go deeper on the part of the clinicians. Now, the judgment issue, I mean, maybe in the next slide do you want me to forward it to your next part?
Sure, that'd be cool. Yeah. So, as we look at what some of the people have written, I go back to the article written by our friends at Mayo Clinic. A century later, the medical profession is still struggling with the same issues that Dr. Codman was struggling with. He was right then and he is right now, but a lot of people haven't paid attention to him. And they go on to say further, we should embrace transparency as a component of our tipping point strategy to ignite the change we all need to transform our organizations and our profession. But if you look at what people are doing,
we'll switch.
You really have to ask about what's the theory behind all of this. So, in a nutshell, this is the theory that we think is the dominant theory. Just take a moment and look at it. The idea is that the more data that you put out there in the public arena for political leaders, the press, the public, the more data out there, the better. The rest of the assumption and theory is that when you do that, the top performers will be rewarded, either by reputation and or resources, and it will motivate the poor performers to get better. Now, I'd ask you, is that the theory behind transparency? Do you think that's the theory? And if not, what's your theory? Because I can tell you this is not going to go away. As much as you curse at it, say it's not a good idea, you shouldn't do it, it is going to grow in importance. It's going to grow because our data systems will allow us to manipulate the data more, have bigger data systems, drill through it, mine it, come up with answers. So what is your theory about what this transparency stuff is all about? I think that you really do need to have a dialogue. One of the things I've learned so well from my friends in Sweden is that we have a dialogue, and there's really a nature about dialogue. It is not an idle chit-chat, a conversation, a debate, a dialectic. It is a deep exploration of the assumptions and theories. Matter of fact, at the center we work out of it, Kulturum in Jönköping, they don't have meeting rooms, they have dialogue rooms. And I think it's so typical of what the work that's going on there does. We sit and talk about our assumptions, our theories, the predictions that we have about how things are going to work. Do you do that within your own organization? It's the road toward understanding and knowledge. Do you use the data that's available? So if you do have national data that comes from some system that gives you rating and rankings in whatever order, do you actually curse those things, or do you actually say, all right, that's interesting outcome stuff. How does our data compare more recently? This stuff is 6 months, a year old. And then what are the processes, the structures and processes that we have in place that produce this? And again, you can harp on an outcome all you want and it never will get better. This would be like if you came to me for blood pressure management and I said, I want lower blood pressure. I want your blood pressure lower, and if it doesn't get lower, I'm not going to be your doctor and I'll take you off my Christmas card list. Right? No matter how much I harp on you, and probably if I did harp on you, your blood pressure would go up because I'm in your face. I'm never going to change that blood pressure unless I look at the structures and processes you put in place. What's your daily intake of fat, sodium, and cholesterol? Do you smoke? Do you drink? If so, how much? How many times do you eat each week at a fast food chain? The exercise. All of those variables are going to drive the outcome. And what I find is a lot of people in these systems now that are starting to put outcome measures out curse the outcome but don't take responsibility for looking at the structures and the processes that they put in place that create that outcome. And just like Alide said, when you get down to it and you say to people, what are you doing day in and day out that produce that outcome? And so what happens is a lot of people do the third bullet. They look for ways to deny the data, distort the process that produces it, or kill the messenger. And what you want to be able to do is take responsibility for your own data. And I'd like you to start thinking about having a dialogue about these questions. One of our faculty members, a physician that works with us, Jim Reinertson, wrote an article about a year and a half ago that has caught some attention. It was, as you see, how to go naked. And the work we've done in Denmark, our friends in Denmark have been very keen on this. So we'll be in meetings and somebody will say, well, we need to go naked. And I can remember seeing a couple people at times that hadn't been familiar with the concept, looking at their leaders going, we're going to do what? But Jim Reinertson made a thoughtful provocation here. And this one-page article that if you're interested I can share with you afterwards, he points out several things, and I've paraphrased, and I told him I would add to it just a wee bit. But his point is you start at the top, and if you look at these bullets, his point was that many times board members, chief execs, non-execs on your board, however they're defined governance, they end up being fed only good information, and the bad stuff is suppressed or whitewashed. And so we run a program at IHI called Boards on Board, and we also run another program called the Executive Quality Academy. And as we've asked people these questions, many of them, in responding honestly, have said, yes, well, we don't always tell the board exactly how bad we are. They only want to hear good news. And so one of Jim's first points is to make sure that you're giving the board the good, the bad, and the ugly, and you're not trying to whitewash it. His second point, and this may be more relevant in the United States than some other countries where we have a very litigious society, don't hide behind your lawyers. I've had numerous times people from the legal ranks tell me, you can't put those control charts or data up because it discloses too much, and somebody could sue us. And I love the line here that this came from a lawyer, actually, at a large health system in the United States, that patients don't sue us because of our data. They sue us because of broken relationships. And I think that's spot on. Third, he said, keep it simple. And this is what we've been doing with all of those who are strategic partners with us, plotting data. You go out on unit in hospital in Scotland, you will find run charts and control charts on the wall where the nurses just plot their data, falls, pressure ulcers, infections, by day. And then it gets transferred later on to a larger data system where we can tabulate it. Same thing happens in Sweden, in Denmark, at Kaiser Permanente. You see people tracking data day in and day out because that's how the process emerges. And if you wait until it all gets aggregated at the end of the month, the end of the quarter, you'll never be able to really understand the quality that's being produced moment by moment, minute by minute. And finally, he makes this point to shape up. And the fact is that we've seen a lot of organizations that don't actually even share data with staff. So if you ask the staff, how are we doing? Alide's question, they go, I have no idea. They'll tell us when we screw up, you know. But the point is that people throughout the organization, if the workers can't tell you what strategic objective their work is trying to fulfill for the organization, then you have a hole, a gap in the way they think and see. And I love his final point here. If you're going to go naked, you might as well be buff and in good shape. And his point is that you need to share what you're doing and be open as well.
Bob, can I add one on that slide?
Yeah.
You know, what I've found over the years is that people tend to make two polar extremes in the argument. One is everything we've been talking about, transparency around data, and then the other is patients rely on that relationship with their physician and story, and the stories that they hear from their neighbors and their friends, and that's where they make their selections about who they trust and have a relationship with. And to me, I feel like we ought to be able to hold both concepts in our head at the same time and say this should be a yes and belief system that the use of powerful stories and powerful relationships with the delivery system people, and in particular their physician, and that trust is profound, and that will never be replaced by a run chart. But at the same time, the old system relied exclusively on that without being able to know overall performance. And we, with where we are in our world today, we ought to be able to merge both views as both being very important in that foundation of trust and improvement in the relationship between healthcare delivery systems and their patients.
So let me ask you one other question. What do you do with the people at the top on this one, with the boards? Do you share with the board the good, the bad, and the ugly on a regular basis?
You know, we have an interesting catch-22. I would say absolutely. Absolutely. But what I have found, because I'm one of the senior staff to our board of directors, is it is extremely hard for CEOs to share the bad, the less than really good. I call it almost an unnatural act, because for them to talk about it, they feel like they have that they would be saying that they have not done a good job,
that they've failed.
And our board actually pummels me and the support people if they're just getting a sell job. If it's only the positive, they go, we have to understand the risk to the organization. But it takes a lot of work with our CEOs and our leaders to say they want to hear where there's risks, and then they want to hear what you're doing about it.
Do you tell stories at each board meeting on sentinel events, on harms, and tell a patient's story about we did this harm to a patient? Are those regular?
We start every board meeting with a patient story about.
So that's a great point, starting it, because I've seen too many agendas where quality and safety are at the end of a board meeting, and they talk about the finance, the budget, the resources, and then by the time they run out of time on the agenda, they table the quality discussion till the next time. But having it at the top of the agenda is a key thing.
Yeah, I think we've learned also to have patient's voice and patient panels in all of our major improvement work at the beginning.
All right, so let me just wrap up with two more slides, and then we'll see what kind of thoughts and questions you have. This is what Codman said right before he passed away. Matter of fact, interesting, Ernest Codman died a pauper. He was so vilified, he couldn't even get work at the end of his career. His colleagues had chastised him so much. And he's buried in an unmarked grave on the edge of the Harvard campus, interestingly enough. But he said this about himself. And he must have been a little clairvoyant in knowing that he was ahead of his time, that I may receive some more, that is, recognition and receptivity in another generation. Don Berwick, who will be our closing plenary speaker and the emeritus president of IHI, wrote this: Codman looked ahead. He looked indeed beyond us. 78 years ago, he began his life's work. 48 years ago, he died. And are we ready for him yet? So what we've tried to do in this session is really to give you a very quick walk through history, as well as some of the issues in contemporary times that are driving this movement toward transparency and greater data release. And so we'd like you to think about these issues. We'd like you to maybe use the dialogue, the questions that we posed in the worksheets and others. And our final challenge for you, our final recommendation, is just this. Thank you. So we have a few moments before our next break. If there are comments, and again, they don't have to be questions. If you have feelings or thoughts about this, we can just start a little dialogue right now. Where are you in your own organization, in your own country? And I don't know if we've seen any Twitter feeds that are provocative.
There's certainly been a bit of discussion on Twitter. Something that's been quite topical at the moment in the UK is about data reliability. So there's been a couple of comments really on how much you can look at your transparency data if you can't really rely on your data that you're actually collecting. So there's more comments about that. Okay. So, I mean, let's get them all out and then we can just see what the audience thinks as well. So a specific comment was that the financial institutions have got high quality data, yet the rating agencies still can't get it right. So what hope does healthcare get?
Interesting provocation, eh?
Yeah.
Any
thoughts on that?
Thoughts, comments, observations? Where are you in this journey? Do you hope that your data, whenever somebody puts it out, looks good? Or do you actively pursue taking these data and starting to decompose them? The outcome measures are always changed slower than the process measures. And if you're not looking at processes, it's going to be very hard to actually change that outcome. So if you want to reduce falls, infections, pressure, some of the big ticket items that Alide showed, those things are going to take a while, particularly if you look at, say, crash calls, mortality, failure to rescue. There's a lot of stuff that goes into making that big dot move. Mats. Hello.
Hello, my name is Ciara Kirk. I'm from Dublin in Ireland. A few things strike me about this. One is that we actually don't have a lot of data about outcomes. We don't necessarily collect. We think we're really good, but who knows?
Just ask you, you'll tell us.
Yeah,
good.
But also, particularly since attending one of your sessions at this conference a couple of years ago, I was really struck by the measurement for improvement versus measurement for judgment or measurement for research. And some of the issues with this are when you're becoming transparent with the data, or the leapfrog group are looking at you, it's really for judgment. So while you've a lot of freedom when you're trying to work out, can you improve and are you improving, and you're measuring for that, the little nuances of are there any particular problems with the data are less significant, whereas when it's for comparison, it's very difficult to get the data right and to have that. So I feel in one way that we're a little bit lucky in that we can kind of just build our data for improvement at the moment because we don't have as many national measures.
Yeah, I think you said it well. That this distinction between data for improvement, research, and judgment is critical. Many of us work in the research realm. I'd say all of us work in the improvement and at some point the accountability or judgment realm. Mats, you may want to comment on the open comparisons because we've gone through this a lot with the outcome measures that are used for open comparisons and how people have been critical of that.
I will do that after that question.
Okay, please.
Thank you very much for the interesting talk. And I wonder whether it would be a defense mechanism to say that some cultures may not be ready for such transparency. Whenever I bring such a topic up, where I come from, and I'm coming from Doha, Qatar, from the GCC, I practice. So it's always the answer of our culture is not ready for it, our patients are not highly educated enough to understand such data, it may just come back at us. And the media is already hard. So is it a defense mechanism to say that my culture is not ready for it, my patient doesn't need it yet?
I think these things all have to be put in in a cultural context. And if you don't, I think you're going to be dead in the water, quite honestly. We've been doing a little more work in the Middle East, and we've gained more knowledge of your country, Saudi Arabia, and some of the others. And I'd say that maybe the first level of transparency is within the health profession itself. And with this day and age, I would think people are even consumers that may not be very well educated or, as you say, not that interested, or that they defer to the medical profession maybe. At some point, some of these people are going to be using their iPhone or the internet to look up stuff. But I would say that probably the first starting point for when a culture of the people isn't ready would probably be changing the culture of the profession itself and starting to be more transparent within the discipline itself.
And can I add one word, Mats? I think to sort of listen and entertain that it is more likely that the people will be ready sooner than the profession thinks they're ready. So if you think about Europe and the U.S., we would still say, "Oh, they're not going to understand it," and or jump to conclusions, and that's bad. Therefore, this parentalism, this paternalism about we need to protect them from themselves. So you may have a window still to have to do the internal reporting as a place to start, but also prepare yourself and the values that the profession will hang on to not being transparent under that reasoning, that the public won't understand it longer if it follows all of us. That's the way we interpreted it for years. It was really this push for transparency came up from the consumer, not internal to the profession.
I just give you a short view of the Swedish comparison. We are 21 regions, and we are compared since 2006 according to more than 150 variables. I think what happened is that we have a discussion now, an open discussion about our clinical result. We had it about finance, it's about access, and it's about patient satisfaction. But this has brought up the clinical results for a much more open discussion.
Exactly.
So I think it's the same experience as in US, as you have fought for an advocate, and it has changed our culture. I want to thank the two presenters, Bob and Alide, and give them a big applause.
Thank you. Well done.
Thank you all for contributing. We are going to have an evaluation early on the net, and now it's the keynote remarks in 13 minutes.
Enjoy the conference. Thanks.